This
Okay, cool.
this conference will now be recorded.
There you go.
So we'll wait for the rest of the guys to come, right?
Yeah. You'll soon have a quorum. Jermaine said he's logging on shortly, and then we just have one more left. I think it's Jesse. All right, I think we could probably get started. I have 2 after 12.
This conference will now be recorded.
Thanks everybody for joining in today for Journal Club. Today we have Shah Chaudhary, who's going to be kind of leading our Journal Club today. It's got an interesting article to kind of go over, and then we'll have a case study to kind of follow. All right, I'll give the floor to you, Shah. Take it away.
All right, thanks a lot. I appreciate it. Yeah, guys, so my name is Shanawaz Chaudhary, EMS fellow, number 462, and we'll get started on this journal article. We'll cover one article and do one case. So the article that I decided to select today was this. It was just released just this past month in the Resuscitation Journal in July 2021. The title is Impact of Intraosseous versus IV Resuscitation During In-Hospital Cardiac Arrest, a Retrospective Study. So just getting started, the clinical question that this article intended to answer was, does IV or IO access lead to better neurologically intact survivors during in-hospital cardiac arrest? I emphasize in-hospital because I'll discuss a recent article that was performed, I believe it was last year, same question, but out of hospital. But this article specifically was in hospital, and I'll kind of explain why it's still relevant to us. So we'll be following the PICO format. So we'll start with P, with population. So what population was studied in this study? It was adult patients greater than the age of 18 years old, those who suffered from atraumatic cardiac arrest between the years of 2013 and 2018 at a single tertiary care center in Birmingham, Alabama. There were a few patients who were excluded, and those patients had either a central venous access already, they were on an ECMO device, they were on a mechanical circulatory device like a left ventricular assist device or an intra-aortic balloon pump, or they had suffered a cardiac arrest in the ED. The reason why the last one, cardiac arrest in the ED, was excluded was simply because this was a retrospective analysis, and it was difficult to determine if the cardiac arrest that occurred in the ED, they were already brought in by medics. So technically that would count as an out-of-hospital cardiac arrest, or if the cardiac arrest occurred in the emergency department. Because it was difficult to discern the two, they decided to exclude those patients, as they would likely be a confounding factor. So what was the intervention? This was, like I said, a retrospective analysis. So I'll go into a little bit more in depth in terms of like how they separated the IV and IO access groups, but this was more so a chart analysis. The comparison, like I mentioned was to compare IV and IO access during in-hospital cardiac arrest. And the outcomes that they were looking for, the primary was survival to hospital discharge. And then the secondary was survival to hospital discharge with favorable neurologic status. And then other parameters that we tend to care about as clinicians that resuscitate, basically rates of ROSC, time to ROSC. And there was a subgroup analysis, which I'll get to later on, but it was essentially looking at the same thing, but for patients that are obese with a BMI greater than 30. I'll explain later on why they did that subgroup analysis. So the outcome, so the final question of the PICO, I guess, the way that we analyze articles is outcome. So the clinically significant outcomes that we tend to care about as clinicians, they were not statistically significant, whether you did IV or IO. And what I mean is there was no difference in survival to hospital discharge and no difference in survival with favorable neurological status. So those two, there was no difference. However, those that were resuscitated with an IO, they had a lower rate of ROSC and a longer time to ROSC. We'll dive a little bit deeper into why these results were, it turned out the way that they did, or at least why I suspect they did. But I don't feel that this is that surprising, but these results are different than, I guess I thought it was gonna be the next slide. These results are different than the study that I was mentioning earlier, where it was essentially the same study, but looking at out of hospital cardiac arrest. And I'll get into that afterwards. So just as like a brief introduction, just to dive a little deeper, intraosseous or IO delivery of medications during cardiac arrest provides a safe and rapid access when IV access is either unavailable or difficult. But the effectiveness of medication delivery via IO in cardiac arrest is not well characterized, specifically in cardiac arrest, because we do understand that IV and IO are relatively equivalent in a normal functioning live human being. But when it comes to those patients that are in cardiac arrest, there may be some physiologic differences, and as a result, the effectiveness of IV versus IO is not well characterized. So this is the article that I was mentioning earlier. This one is more relevant to clinicians that practice in the field. IV versus IO adrenaline. Adrenaline is epinephrine. Europeans tend to use that term, adrenaline. So IV versus IO, I'll just say epinephrine administration in out-of-hospital cardiac arrest, a retrospective cohort study. Essentially, the findings showed that the IV approach appeared to be the optimal route of epinephrine administration during pre-hospital resuscitation involving an out-of-hospital cardiac arrest. And you can see the chart on the upper right. That kind of just breaks it down. Essentially, you can see whether we're looking at pre-hospital ROSC, survival to hospital discharge, or favorable neurological outcome. IV was superior to IO, and it was statistically significant. Clearly, our results, that at least we see on the article that we're reviewing today, are different than these. We're not diving deep into this article because I'm sure this article has limitations as well, but the results are different than this. Whereas basically our article found that there was no difference in survival or survival with neurologically intact survival. So what were the methods? So essentially in this hospital, anyone that had an in-hospital cardiac arrest, they had a MET team respond to them, so a medical emergency team. Essentially what was done was the default procedure is to use any pre-existing IV. If there is no IV or it is a non-functional IV, an IV would be attempted, but if by the time the MET team arrived, there was still no functional IV, an IO would be placed, and the IO location would be the tibia or humerus. I'll get to this later on, but there are going to be limitations to this study, and one of them simply was they did not document whether it was a tibia or humerus IO, and that is a limitation, as I'll get to later on. What were the data that was collected? Amongst the data that was, this was like the most important data. Essentially, which route was used, IV or IO, the time to first epinephrine dose, the total time of cardiac arrest until the first ROSC, whether the cardiac arrest was witnessed or unwitnessed in the hospital, what the initial cardiac rhythm was. There's some basic demographics like age, sex, BMI. The reason for BMI is because there was that subgroup analysis. Survival to hospital discharge and post-arrest neurologic status scored by the CPC score. So this is the general breakdown of the patients that were recruited. The total number was 8,852 that were reviewed, but 1,039 were selected because of the exclusion criteria. And you can see about 832 were in the peripheral IV and 207 were in the IO. And when they broke it down by BMI, those with a BMI greater than 30 or those that were obese, there were 320 in the peripheral IV and 87 in the IO. So right off the bat, you can also see, from a, just criticizing standpoint, there were just clearly much more patients in the peripheral IV access group. And when you go all the way down to those that were resuscitated with an IO that were obese, there were only 87. So that, this is going to affect the results that we are seeing. Over here, a lot of numbers and words, but essentially all we should really look at is, unfortunately in statistics, we are held to the p-value. So a p-value less than 0.05 would be considered statistically significant. So these are less than 0.05. And what we can see here is essentially that those that are resuscitated with an IO were more likely to have an unwitnessed event. So again, those that were resuscitated with an IV, about 86% were witnessed. Those with an IO, about 80% were witnessed. So more patients were unwitnessed arrests in the IO. And again, that's going to affect the results because we all know that patients that suffer from an unwitnessed cardiac arrest, because there's less or there's a longer period of time where there is no flow to your essential organs like the brain and heart, you will have worse outcomes. So that may be one of the reasons why we're seeing the results that we're seeing. And then the other thing that you can see here is you can see time to epinephrine. There was a longer time. So let's just say 2 minutes and 30 seconds. That's the time to the first dose of epinephrine. And those that were resuscitated with an IV, but those that were treated with an IO, it was about 3 minutes. So about 30 seconds longer. So again, that's going to affect the results. But at the same time, clearly, there was technically no clinically significant difference between IV and IO. What I mean, again, is there was no difference in survival or neurologically intact survival. So this 30 seconds clearly is not, I guess it doesn't really seem to affect the outcome either way, because it's not like the peripheral IV group had better outcomes because they were given epinephrine 30 seconds earlier. So a little complicated, but basically, we can see that in general, patients that were treated with an IO, it took longer for them to get epinephrine, understandably, likely because an IV was being searched for. And then this is the last table that I'll review, which is basically, the clinically significant outcomes of survival to hospital discharge and survival with favorable neurologic status. There was the p-value is not less than 0.05, so there was no statistically significant difference whether a patient was resuscitated with an IV or IO. But you could see that there was a longer time, a lower rate of ROSC, 72% versus 80%, in patients that were resuscitated with an IO, and there was a longer time to ROSC, around 10 minutes versus 8 minutes and 40 seconds, in patients that were resuscitated with an IO. So finally, just in regards to the subgroup analysis, in regards to obesity, the reason why this subgroup analysis was done was because prior studies have shown that being obese is just an independent predictor of getting, of being a difficult peripheral IV access, of getting peripheral IV access. So should going straight to an IO be better? And it shows the outcome? No. There's no statistically significant benefit or harm with use of IO compared to IV in terms of overall survival to hospital discharge, favorable neurologic status, or in this case, there also was no difference in the return of ROSC, the rate of ROSC. There was an association between IO axis in these obese patients and longer time to ROSC. And I'll get into that why, but likely, these obese patients, we try IVs unsuccessful, we try IOs, they may not always be successful because landmarks are different, the needles that we use may not be long enough, etc. Sometimes we inject it into subcutaneous tissue without realizing. So, and again, like this is essentially the same, exactly what I just explained, but in the form of a chart, where the only difference or statistically significant difference that you see here in obese patients is that it took, compared to peripheral IV, IO took a longer time to achieve ROSC, about 13 minutes versus 9 minutes and 22 seconds. So the results, again, to just summarize a little bit, the study I presented to you, it suggests that there's an association between IO medication delivery and inferior rates of ROSC and longer time to ROSC in those who suffer in hospital cardiac arrest. And after adjusting for confounders, there was no difference in survival or neurologically intact survival. Yep. And so again, I was kind of alluding to several of these, like why the results are the way they are. For one, literature supports that there is a bioequivalence in terms of like maximum serum concentration and time to peak effect of drugs that are administered in the IV versus IO. But there are likely physiologic difference in patients who are in cardiac arrest. So, although we consider IV and IO to be equal, and patients that are in cardiac arrest, they are likely different. Data suggests that anatomic site of IO matters. Like I had mentioned earlier, they did not differentiate whether a tibial or humerus IO is being used. Humerus is closer to the heart, so it's closer to central venous axis, and so that this is another confounding factor. Like, were mainly tibial IOs used, and therefore that might have contributed to worse outcomes, versus if all IOs were used, maybe that would have resulted in better outcomes. Not sure, and so therefore it's another confounding factor essentially. The different, actually I won't go into that one. Basically, the first point I mentioned was essentially, remember when I had mentioned that patients who were resuscitated with an IO, the time to first epinephrine dose was about 30 seconds longer. Although 30 seconds in the cardiac arrest we would consider to be a significant amount of time, clearly it did not result in any clinically significant better outcomes. Even though patients got epinephrine 30 seconds faster in the IV group, it didn't result in better survival anyways. And then finally, there were more unwitnessed cardiac arrests in the IO group. Like I had mentioned earlier, by default, this means that, or it usually translates to the fact that if there are more unwitnessed arrests, you're likely going to do worse. And that's why we're possibly seeing these results. And again, in regards to the obese subgroup, basically, it's likely, even though these patients, we typically associate them as having, simply being obese as being a predictor of not being able to get peripheral IV access immediately. I mean, the same likely holds true for IO. They may also be a difficult patient to get IO access in. So, that's probably why we saw the subgroup analysis results. Limitations amongst the many that I described. I mean, for one, this is an observational study, so it's not, a prospective, double-blinded, like a study. This is a retrospective analysis. There were multiple confounding factors that we weren't able to account for. One of which I did not mention which was simply they did not account for the severity of illness. So what if all the IO patients, the majority of them had worse comorbidities? Well, that explains possibly the results. there was incomplete data, like I had mentioned, that they didn't really account for where the IO was, applied. And also, in the middle of a cardiac arrest, we don't know how the cardiac arrest went. Like, what were the drugs that were administered? When were they administered? What was the time to defibrillation? What was the airway management? What was the nature of the post-arrest care, et cetera? So there were a lot of missing data that could certainly affect the results. There was a selection bias. This is simply a single urban tertiary care center in the US, so it may not apply to everyone. And finally, there was like a grouping fallacy, which is essentially, even though, like I had mentioned, if a patient did not have a functional peripheral IV, an IO would be used. We don't know if that, even if they got an IO, after they got the IO, did they end up getting an IV and then the IV was used? So we don't really know if the IV IO was essentially used throughout the entire cardiac arrest. So again, even though a patient may have gotten an IO and they were grouped into the IO category, we don't know if eventually down the line they got an IV and the IV was being used. So there were just some missing pieces that could have certainly affected the results. And like I mentioned earlier, there were only 207 patients in the IO category, and in the subgroup analysis, there were only 87. So in conclusion, IO compared to IV during in-hospital cardiac arrest was associated with worse rate of ROSC and longer time to ROSC, but no difference in overall survival or favorable neurologic outcomes. And IO placement should remain the alternative during resuscitation efforts after failure of peripheral IV, regardless of BMI, and at least be considered a bridge to more definitive access. So some quality checklists for observational studies that, essentially the answers that I could have given were yes, no, or unsure. I feel a lot of these were likely unsure, but I'll just give you my interpretation of it. Did the study address a clearly focused issue? I think that the question was simple, but just because of the nature of the number of confounding factors, I'm unsure if it addressed the issue. Did the authors use an appropriate method to study? Obviously the best method is a prospective randomized controlled trial, but I'm sure it's very difficult to do that, and I'm not exactly sure if it could be done ethically. I'm sure it could, but I do think that it was an appropriate method. Nonetheless, this was a retrospective cohort analysis. Was the cohort recruited in an acceptable way? I think it was, but obviously it was just at one center, so maybe it could have been better. Was the exposure and outcome accurately measured to minimize bias? I think it was. They used the data that they had, and they tried to extract as much data as possible, and so I think that there wasn't a bias in collecting or exposing patients. Were all confounding factors accounted for? No, as we had been discussing. Was follow-up on the subjects complete? I believe they were. Essentially, the primary and secondary outcomes that we were looking at, they were all, the subjects were followed up on. How precise are the results? With the data that they were analyzing, I think it was precise. Do you believe in the results? I do believe in it, but obviously just keeping into account that there were a lot of confounding factors that could have affected the results. Can the results be applied to local population? It depends what population you're in, but sure, if you're in an urban center, likely yes, but maybe if you're at a rural community shop, maybe not. And do the results of the study fit with other available evidence? There is technically no other study, from my understanding, assessing IV versus IO in in-hospital cardiac arrest. But like I had mentioned, there was that study done a year ago assessing out-of-hospital cardiac arrest, and that study found that IV was better than IO. So I guess it does not fit the available evidence. And so how do we, having analyzed this study thoroughly, how does it affect or apply to my daily practice? I will continue to advocate IO if IV is difficult or unavailable. In my opinion, IV access will continue to be searched and attempted during cardiac arrest without affecting the critical actions of the resuscitation, especially if I'm resuscitating this patient in the emergency department. We by default have just more people and more tools to get IV access, whether that's ultrasound or central line. But in the pre-hospital setting, I still feel if IV access is impossible, IO is adequate to perform and terminate resuscitate efforts as well. So I could move on to the case, but I think this is probably a good time to just have your thoughts in regards to what you guys think of the article or the presentation.
Great summarization, Shah, of the article. I'm going to be the guy that may rain on the parade, I guess, a little bit. You know, my thoughts on this is that does it really matter if you get an IV when we know that epinephrine that we're the thing that we're looking at doesn't really change outcomes anyway, you know? And I always say this, that we keep doing studies on epinephrine over and over again when, you know, we know that there's little to no benefit. You know, you're getting that increase in ROS, but, you know, the actual, you know, end survival and like their CPC scores aren't really going to be statistically significant. You know, that being said, I mean, you know, it's one of those things where, you know, I think people are still going to want to study and still going to want to, like, you know, kind of harp on to see what kind of survival we can have. You know, it's always been kind of argued whether IO versus IV, and I think one of the things that we're talking about is a couple things. One, the in-hospital setting, I can argue that the level of comfort of anybody who's doing an IO, who's not probably in the ED, who's on a floor, is going to be very, very poor, versus you taking a medic on the road and tell him to drill somebody. They're going to be a lot more comfortable, and they'll definitely get their landmarks probably a lot more clear than someone in the inpatient setting. So I think even though that this study did talk about how there were, you know, yearly certifications on online modules and some simulated code events in a cadaver lab, you know, there's only so much of that you can kind of mimic in the real kind of environment. And then, you know, this MET team of nurses, like how many of them were, you know, how many of them really kind of did it and to what frequency? So, I mean, how many people are on this team? And so how many times did really one nurse possibly deploy an IO on a patient? You know, was it, you know, maybe 4 or 5 times in the period of the several years that they did the study from 2013 and 2018? You know, or was it like, you know, every week that they were deploying it because they're working every single day or, you know, doing all these codes? So it's variable. The other thing is that I think that, you know, obviously you're looking at this response team. These teams are not on the floor. So what you're having is you're having patients who are most likely on the floor, and we know that most patients who go to a floor have an IV, you know? And so what ends up happening is that they're getting meds and they're getting drugs pushed, you know, and so their rate of ROSC is going to be definitely skewed because obviously most of the patients will have an IV. And if you think about this, is that when that response team comes to, you know, the bedside, they're not coming right at the time of cardiac arrest or, you know, within minutes. It's taking them a while. So by that time, you've got someone who's been down for quite some time. And so intuitively, you know, your opportunity or your ability to obtain ROS is going to be blunted. And then furthermore, I mean, you know, I get the obesity kind of, you know, play on this, but, you know, at the end of the day, these patients are harder to do chest compressions on, plain and simple. You know, these patients are harder to continuously do high quality CPR on. And so these patients are continually going to have poor outcomes. What we're not realizing is we got to go back to the basics, you know, and the basics is good airway management and good CPR. High quality CPR is going to be where the money's at, right? And early defibrillation. And so if we can get early defibrillation soon, if we can do high quality CPR, you know, we're not going to really, at the end of the day, achieve what we want to achieve, which is, you know, good neurological outcome. So, I mean, in my mind, I mean, I take it that these patients in the inpatient setting are going to be harder to do chest compressions on. These patients are, you know, they're chaotic. If they're unwitnessed, more unwitnessed in the obese population, those patients are going to be much harder to bring ROS back on, especially because the fact that you're now behind the ball and you now have to do chest compression on someone who's very obese. So I think that all that kind of coupled is a challenge. And like you said, there's confounding factors. But intuitively, when I look at this and I say, well, what could be some other reasons as to why this is happening? I don't think it's necessarily just an IO versus IV, because we've looked at, you know, epinephrine over and over again and what it can do and what it doesn't do. And we've kind of beat it to death. But I mean, I think it's other things that can kind of play to this. But to this specific article, I think you're right. People will continue to try IVs. They will continue to try to place an IV, and they won't go towards an IO. And I make this argument all the time. If you have a patient, if you can quickly look at a patient and you see, just pipes on their arms, go for the IV, no problem. But what we should do in the pre-hospital setting is when we look and we see there's someone who's a vasculopath, what's the point of putting a tourniquet on, when they're in cardiac arrest, trying to find a vein, it's just drill them. And I mean, this is kind of the same, mantra of, some people wanting to, take the time to do the intubation, look for the airway versus just dropping a supraglottic airway and ventilating the patient, appropriately. And you'll see lots of schools of thoughts, and it's just people's comfort level, people's desire to do procedures, and kind of do these kind of stepwise fashions. And I think once we get to that point of where we kind of go back to the basics of how we manage patients in cardiac arrest and optimize them, that's kind of where I think we'll see big differences. That's just my take on it.
Yeah, there's been some pre-hospital studies where they've basically proven the non-inferiority of IO, but we all know that when you're trying to look for an IV, sometimes it's easy, you get it on the first shot, sometimes you don't. This is the same problem that we come with double sequence defibrillation. Are we just given the therapy too late? Same thing with the IO. Like, do we have worse outcomes with the IO because we're starting them too late? In this study, I was looking specifically at the in-hospital study because I was hoping that there would be more rates of witness cardiac arrest, and apparently there are not. But there's a distinct difference between people who are witness arrest and people who are found down. And there's some systems where you get dinged if you don't go for the IO first. Things like that, unless there's a contraindication. There are systems where you look at you put the IO, you get ROSC, and then that's when you do your intubation. And these systems of care, and this is why Dr. Wan's pushing for like the cardiac arrest registry, is to kind of track these things and kind of look and see what can we do to tweak, what can we do to make things better. But like Amandeep said, Dr. Tagore, that if you have to work on your basics. If you don't have your basics down, this is what we found with PICC group CPR as well. If you don't have your basics down, doing these more advanced things doesn't help. And that's why AHA changed the recommendations a couple of years ago to focus on the basics.
Ditto. But really important points, because when we talk about cardiac arrest, what we're trying to do with CPR, and that's why the CPR is a level 1 recommendation, high quality minimum CPR, is really perfuse the brain. If we don't maintain perfusion in the brain and we now have an anoxic brain, that's the one thing that we cannot fix. There's nothing else we're going to do for that patient. CPR buys us time to figure out what can we reverse. And like Dr. Tagore said, we've seen study after study after study about epi, yet there's limited truly question of whether epi truly works. And that was my take when you're doing, again, a wonderful presentation on this paper. My thought is, hey, it's probably because epi doesn't really work. It just gets pulses back. You can give people enough epi and it'll get pulses back on rocks, and we've seen it. But this is also the issue with the literature, and I think we see this even in our own EDs. A lot of times when we have codes, the nurses are constantly trying to put an IV in. They're trying to, with a 24 gauge and whatnot, and you're just like, here's an IO, let's just drill an IO. Whereas in EMS, they're much more willing to jump right to that IO because they've been through this process. They know this saves them the time. So it is interesting to see the difference. Although one other point that was interesting to note, if, I don't know if this really would pan out, but in theory, if the population that was getting IOs were less likely or unwitnessed arrest to begin with, and thus theoretically a poor prognosis, and had a longer time before the vascular access was established with the IO, thus again, poor prognosis in general, in theory, does that mean if these were IOs done on patients with witnessed arrest, within that same time the IV was established, or within that same time that the first epinephrine was given, would they potentially have better outcomes if the premise is that epinephrine actually has some benefit?
Dr. Wong, that was going to be my point exactly. Looking at this, we can't really stratify, I think the way that we should look at this, and if we're going to do a study, is we need to stratify the patients according to the Epstein criteria and compare apples to apples. We need to look at it as witnessed arrest with either bystander CPR or immediate CPR in the hospital, and then look at the first attempt. If they went for the IV first, if they went for the IO first, there's nothing saying here that these didn't, try 3 or 4 attempts at an IV and then finally go to an IO. And that would just delay it even further, because it's actually quicker to start an IO than it is an IV.
The other thing that also I think that we should that should be looked in this study is like, is the inpatient team is putting an IO part of their competency, because like I know, like for now the nurses, they're much more comfortable doing the IV because maybe during the training they really didn't have any IO training. So that's another thing, because if you go for whatever you're comfortable with. So if in part of the training is like, you know what, if you like, this is an IO, this is how you do an IO, this is much quicker, this is just as effective as an IV, and they have this understanding, maybe they would tend to go more, because we get a lot of patients that they are obese, drug users, immediately that you're not gonna have like an easy IV. So if part of the competency is like how to put on IO, how to successfully put on IO, and is just as acceptable as an IV, that's one thing we have to find out if that's even part of the competency.
Very true. It's similar to the whole debate on intubations, where you're comparing people in the Midwest that intubate once a year and then saying that they're not competent. Well, of course they're not competent. They're not doing it on a regular basis.
I think one of the things that I kind of allude this to, and kind of Navin mentioned this as well, is talking about the deployment of the IO, not as like kind of as a last resort or like as a backup, but like you mentioned, Steve, like kind of initial and a head-to-head comparison of like, this happened first and that was my first attempt, and this is kind of how we deployed it. I always say that we should definitely do a study the same way with double sequence, and double sequence being the first kind of attempt, or at least a second attempt, not like the 5th, 6th attempt 20 minutes into an arrest. I think that's why the numbers and the data is so poor. I think all these types of interventions that we talk about, when we do them up front, take them away from a secondary or a tertiary kind of option and make them the primary. I think we would start resuscitating people much easier. But I think us as providers in the field, we're much more, especially as our comfort level increases, we're much more inclined to do these interventions sooner and quicker, because we realize that it's just that much easier to do. But this is a great kind of conversation. I liked it. Shad, do you want to go over your case now?
Yeah, what I'll do is I'm glad we had a long discussion about this. My case initially was going to be a little bit interactive, but what I'll do is just to make sure that we're on time, I'll just kind of go through it relatively quickly. And obviously you guys can pause and let me know if there's anything you want me to make sure I didn't miss.
Thank you.
All right. So I titled it Sleepy After Assault. I don't know, I tried to be a little catchy, but I couldn't come up with anything, but here we go. So this is a 58-year-old male that was brought to the ED after a physical assault. He was reportedly punched in the head multiple times by a gang. A patient was on the floor outside of his house, and bystanders called 911. The bystanders reported to EMS that the patient passed out, and they essentially just waited for first responders to arrive. And when EMS arrived to the scene, they reported to me that the patient was oriented to person in place, not time. He was generally confused, and he complained of a headache. So EMS tells me that they placed him in a cervical collar, carefully transferred him to the stretcher and loaded him into the ambulance. He had an abrasion over the right side of his forehead, and so they put Curlex and gauze over it, and they got vitals, which showed a blood pressure of 138/80, heart rate of 112, pulse ox of 98% on room air, respiratory rate of 14, and glucose of 107. So it so far seems relatively stable, and vitals are essentially normal with the exception of heart rate, a little bit tachycardic. They en route to the ED, they got an EKG. And this essentially is just sinus tachycardia at a rate slightly over 100. No acute ST wave abnormalities. The reason they did this was he was tachycardic and he also had a syncopal event, or he had reportedly passed out. So upon arrival to ED, when I saw the patient was generally somnolent and sleepy. He was arousable to voice. I labeled him at the GCS of 14 because of just some mild confusion. Just for the thoroughness of a neurological exam, I performed a Cincinnati pre-hospital stroke scale that was normal, an NIH stroke scale that was 0. He did not have any focal neurological deficits. However, I noticed his right pupil was larger than the left. The patient, like I said, he was somnolent and sleepy. He was answering all my questions, and he says, "Oh yeah, that's normal." I wasn't sure if he was hallucinating or like a little delusional, or if that truly was true. And so I took his word for it. But his main complaint was essentially he was complaining of a headache. Obviously, when I was doing this, I was already assessing his primary survey. He was talking to me, so his airway was intact. His pulse ox was 95%, and he was not in any respiratory distress. And his blood pressure when he was with us showed he was a little hypertensive at 168/92, and his heart rate was 88, no longer tachycardic. I briefly reviewed some of his medical history, and he tells me that he is on Xarelto for history of AFib, and he's a social drinker, and he denied any allergies. So in terms of differential diagnosis, obviously the first thing that we think of whenever we're thinking of trauma, head injury, and headache, we're thinking traumatic brain injury, and essentially any type of intracranial hemorrhage, such as a subdural hematoma, subarachnoid hemorrhage, epidural hematoma, etc. But just some other things to not forget, at least from the emergency department side, is, I performed a Cincinnati pre-hospital stroke scale, and I just to be on the safe side, but just think about ischemic CVA, think about seizures, intoxication. He reports intermittent intoxication. We all have cases where the complaint was intoxication, but I'm sure eventually a CT head was done and it showed what we see on the left side, the subdural, subarachnoid, epidurals, etc. It could be metabolic encephalopathy, hypoglycemia. They got a sugar in the field, so we know it's not that. Hypercarbia. You could have an elevated CO2 level that could be PaCO2 level that could be causing him to appear altered. Just think about these other things. Obviously, it's unlikely that this would occur after the story that we're told, but just something to keep in mind. So just a real brief review of the different types of brain injuries. Essentially, like in the middle, we have the subarachnoid, most commonly because of ruptured berry aneurysms. On the CT, it looks like the bright red hyperechoic fluid that we see here. It tracks along the sulcine fissures. This is most commonly characterized the worst headache of life. He didn't necessarily say that. He just was reporting a headache and he was sleepy. Subdural, which is most commonly due to rupture of bridging veins. We see this commonly in elderly patients, even after a very mild, like even if they stumbled on a few steps and didn't necessarily hit their head. These elderly patients, their brain is relatively small compared to the size of their skull. And so sometimes that shearing force will rupture one of these bridging veins and cause a subdural hematoma. It's most commonly appeared as crescent shaped. And finally, epidural hematoma, which, I haven't personally had a case like this, but reportedly they have a lucid interval where they pass out, then they're normal, and then they pass out again. And the reason for that passing out again is because this hematoma, which is most commonly secondary to the middle meningeal artery, starts to expand, and then it causes midline shift, et cetera, and then they pass out, and it's a lentiform shape, and it's most commonly associated with a skull fracture on that side. So obviously, given our differential diagnosis in this patient, we ordered a CT head in addition to other lab studies, which I won't go over because it essentially didn't change anything. His CT head showed the following: that there was a traumatic subarachnoid hemorrhage in the right parietal region and trace bilateral convexities suggesting subdural hematomas. There was no midline shift. And then he had multiple facial bone fractures. So the reason why I'm going over this case is it's mainly just for a review of some things that we could do in the pre-hospital setting, even if we don't have a CT scan to prove a brain bleed, but we still have a high suspicion of one. And so there are certain things we can do. And so I'll just hopefully review some of that stuff, and you guys can let me know what your thoughts on it are as well. So traumatic brain injury, it's a major burden on the healthcare system, approximately 10 million annual victims worldwide. Those who survive primary insult often have secondary insults, and I'll just explain to you what the difference between primary and secondary injury is. And those patients that do suffer these secondary insults suffer long-term disability. These secondary insults can actually be identified and addressed pre-hospitally, and that's why I feel like it's relevant to us. And knowledge of these variables and timely management of this disease can significantly improve outcomes. In general, the most common cause of traumatic brain injuries is motor vehicle accidents, fall from heights, assaults, accidents, gunshots, etc. We can separate out traumatic brain injury from blunt to penetrating. In this guy's case, it was blunt. Even though he had an abrasion on his front forehead, it was mainly blunt. I did not see any penetrating injuries. And then we could separate the type of injury from primary to secondary. Primary is those brain bleeds that I had described. If they have a brain bleed, that is their primary insult. It is, oftentimes brain tissue is destroyed by primary injury and is very difficult to be salvaged, but that's why it's best they be brought to a center with CT capability and neurosurgical evaluation, so that if needed, they could get a burr hole or decompression, etc. The secondary injury is where I'm going to be hopefully at least seeing if we could do something about this pre-hospitally. It's the sequel of primary insult and is potentially treatable. So kind of complicated, a lot of words here again, but essentially primary injury are these, like epidural hematomas, subdural hematomas, etc. But the secondary injuries are those that we could certainly address pre-hospitally, such as hypoxemia, hypercapnia, hypotension, intracranial hypertension. Well, obviously we don't have ICP devices, but there are signs to suggest the patient has elevated ICP, and there are certain things we can do to address that pre-hospitally. Hyperthermia, seizures, hypo or hyperglycemia. So these are all things hopefully we'll be able to address pre-hospitally. So in terms of initial evaluation, there are some things that the emergency department as well as consulting docs like neurosurgeons tend to care about. And so just when initially evaluating a patient, a GCS score, it's something that's been done for a long time. It's a useful predictor for outcome, and it can be utilized in the pre-hospital triage for patients that suffer from traumatic brain injury. It's an early non-sedated GCS has been shown to predict prognosis, and so therefore a higher initial score tends to predict better recovery. But essentially the way I've seen it used was it just helps us communicate with each other. Obviously someone with a low GCS score, we think, okay, this is not good, versus those with, like, let's say a GCS score of this patient that I was treating, 14, not bad, right? So hopefully his prognosis will be will be good. And my conversation with the neurosurgeon, it will maybe possibly make him triage in his own mind too. How urgent does this guy need for example, like a decompressive craniectomy, etc. Systolic blood pressure, that's important, simply because, and I'll get into why, but obviously if someone is having a brain bleed, having a higher systolic blood pressure suggests maybe his brain bleed can worsen because there's more blood going into that space, and that could be bad, and his ICP could get worse, etc. And respiratory rate. Reason why respiratory rate is important, like I said, some secondary injury that we could address is hypoxemia. That is important in these patients, and I'll get into why. But also, I'll get into Cushing's triad. Irregular respirations suggest possible development of elevated ICP, and so, this initial evaluation in patients with traumatic brain injury is helpful to us. Transport, obviously rapid transport, ideally to a hospital with CT capability. I believe all hospitals should have it, though I'm sure there are hospitals where it's down or there is none. And ideally to a trauma center, though, of course, any facility where a patient needs to be stabilized is, I'm sure, appropriate, but you know, it's better to be at a trauma center and one with at least neurosurgical capability. Initial management. So again, with the secondary, I'm going to be speeding through this, hopefully get done in 5 minutes, but hypoxemia, you know, we got to maintain a clear and unobstructed airway. We should just assume, especially in an obtunded patient, that their cervical spine is injured, so it must be protected until it is definitively cleared. Rapid sequence intubation is extremely important in these patients. If you do decide to intubate them, and I mean that they must get a sedative and paralytic, and the reason for the paralytic is to hopefully prevent that sympathetic surge when the airway is manipulated, because like I said, hypertension is bad in these patients as it can worsen the bleed. Lidocaine is controversial. It's again another medication that can be administered to blunt the gag reflex and reduce the sympathetic surge. Like I said, it's controversial because it's questionable whether it really works, but it certainly can be used without producing adverse hemodynamic changes. Ketamine, again, is controversial. It was in the past, or you know, even present by some facilities, considered do not give in traumatic brain injuries because it can increase ICP. But there have been recent studies to suggest that there are neuroprotective benefits and anti-epileptic effects, which certainly can benefit these patients. And then just some low-tech stuff that doesn't require much. Just elevate the head of the bed greater than 30 degrees, and that will hopefully keep their ICP low. You want to avoid hypercarbia and hypocarbia. You want normocarbia and eucapnia, basically a PaCO2 of between 35 to 40. Essentially, brain vasculature is very sensitive to CO2. When you hyperventilate, it decreases CO2 levels. It causes brain arterial vasoconstriction, which can be good temporarily in patients with an elevated ICP, but in the long run, it can result in rebound hypertension and increased brain swelling. And you want to avoid hypercapnia because elevated CO2 level causes the opposite. It causes vasodilation and it can increase ICP. You want the sweet spot, which is eucapnia. So all these patients, ideally, you want to maintain them continuous monitoring of their O2 sats and capnography. And you want appropriate, if they are intubated, positive end expiratory pressure, probably 5, likely not more, though. Again, there's not enough studies. This is all physiology. The reason for this is excessive PEEP may threaten to increase the pulmonary vascular resistance by compressing the pulmonary microvasculature. This impairs right ventricular function. It increases central venous pressure and increases ICP. Though, like you don't want to do a PEEP of 15, but you know, PEEP of 5 should be adequate because ultimately PEEP that improves lung recruitment, ultimately, you know, improves pulmonary vascular resistance, reduces right ventricular pressure, and lowers central venous pressure. So I just threw that in there just as more of a, because it is something that I read and I thought it was interesting. You want to avoid hypotension and hypertension. The sweet spot is keeping a systolic blood pressure greater than 110. You want to keep it above 110 because hypoperfusion to the brain means less oxygen to the brain, meaning they will get worse because the brain needs oxygen. And so if they're hypotensive, consider IV fluids, even consider vasopressors. If they are hypertensive, however, you likely want to reduce that blood pressure less than 140 because, again, hypertension can worsen ICP. And pre-hospitally, what we could assess for is this Cushing's triad, essentially a wide pulse pressure. So an elevated systolic blood pressure, a low diastolic pressure suggests a wide pulse pressure. Bradycardia and irregular respiration suggest Cushing's triad. And so there are some things that we can do to hopefully reduce the development or worsening of this Cushing's triad or increase ICP. Normothermia, we do induce hypothermia in patients that are in cardiac arrest because it has been shown to have cerebral protective effects, though this is not an accepted practice after traumatic brain injury as of yet. What we should do is at least maintain normothermia because fever increases cerebral metabolic stress, consumes oxygen, increases intracranial pressure, etc. So when you can if you can maintain normothermia, that would be ideal. Thinners, it is very important to find out if these patients are on anticoagulation because there are reversal agents that we can administer, at least in the emergency department. We all talk about this, but TXA in patients that who we suspect have intracranial hemorrhage from a traumatic brain injury. The CRASH 3 trial shows that there is slight benefit in patients with a GCS greater than 9, but not necessarily benefit for those that are completely obtunded and with a GCS less than 9. These are, I'm not going to go too much into this just for time purposes, but for each anticoagulation that patient has, we can consider certain reversal agents. And I did this on our patient. Seizure prophylaxis or treatment, again, just like fever, seizure consumes oxygen. It's exhausting to the brain. So either prophylactically, we can consider Keppra. And obviously, if a patient is actively seizing, we should give them anti-epileptics. ICP management, I mean, we can consider bolus hypertonic saline, like 250 cc, 33% saline bolus, but ultimately, and you can consider temporary hyperventilation if these patients are intubated, but ultimately these patients need a decompressive craniectomy by neurosurgery. And so in conclusion, high suspicion, we should always have one for if we're suspecting hemorrhagic traumatic brain injury. We should secure the cervical spine, do simple stuff like maintain the head of the bed to 30 degrees. You want to keep them on a pulse ox and end-tidal CO2 to make sure that they are adequately oxygenating and ventilating. You want to maintain their systolic blood pressure between 110 to 140 to avoid hypotension and hypertension. You want to make sure that they do frequent neuro exams to make sure they don't develop Cushing's triad, and if they do, there are those rescue methods I mentioned. You want to maintain normothermia. You want to consider seizure, definitely seizure treatment, but consider seizure prophylaxis in these patients. Consider TXA, but obviously it depends on who and where you go to in regards to neurosurgery or the facility liking it or not liking it for their patients. And obviously you want rapid transport to an appropriate facility. And that's it. Comments, questions?
Good talk, Shaw. That was great. I find this kind of always fascinating to kind of go over these types of talks. I would say, just a couple comments to some of the interventions. I would say no to lidocaine. I would say yes to ketamine. I think it does have some neuroprotective anti-epileptic kind of features. The one thing I will say is, we always talk about this. Everyone's kind of hopping on ketamine, and it's just usually when you have a patient who's like hypertensive tachycardic is usually the one that you kind of want to avoid. So that's the kind of patient, we always talk about, like the shock index being the one that we kind of, shy away from. So typically it's, those patients that I typically wouldn't use it for induction, but otherwise I think it definitely is a go. Just a fun factoid, just because, it is what it is. So, unequal pupils, it's anischoria. Do you know the the physiologic kind of presence in the general population, what the incidence is? It's like 20%. So it's an insane amount of people that have unequal pupils. I don't see that many. That would be 1 out of 5. But I had never seen that many. But supposedly it's out there. So interestingly enough, whenever you have a trauma patient, I'll say see unequal pupil, you're like, oh man, this patient has something significant. And it turns out, the CT is normal. That's probably that one patient that you found. That's your 20%. And but either way, we got to kind of chase our exam, and I would always kind of err on the side of caution. But I always find that to be a fun factoid. Anybody else? All right. Well, we have 1 minute to spare. Thanks everybody for hopping on today. Greatly appreciate everyone being on, and we'll transition for the fellows onto our weekly conference meeting on our separate link. Thanks, guys. I appreciate it.
Thank you, everyone.
Thanks.